very important class of drugs are the anti-diabetic drugs. Before I get into the anti-diabetic drugs, let me just really briefly review what is insulin, since fundamentally the problem is insulin. There are two major types of diabetes, and even those are further subdivided. But the fundamental problem in diabetes is either number one, the patient isn't producing enough insulin, which is primarily type 1 diabetes, or they are producing insulin, but the cells of the body have become resistant to insulin. They are not responding to the insulin. This is known as insulin resistance because of decreased sensitivity of the cells to the action of insulin. That's really type 2 diabetes. The pancreas is a very unique organ. Anatomy and physiology teachers always like to test about it because it is the only organ in the body that is both an endocrine gland and an exocrine gland. Most of the pancreas is actually an exocrine gland that produces pancreatic juice, rich in digestive enzymes that are carried by a pancreatic duct to the duodenum or duodenum, and those digestive enzymes are involved in digestion of food. In fact, that's the major function of your pancreas. But there are these clusters of cells scattered within the pancreas known as pancreatic islets. The older name was islets of Langerhans, after Dr. Langerhans who first described them. And there are two principal kinds of cells within these pancreatic islets. There are really more than two cells, but two types, but two major types, what are known as alpha cells and beta cells. And the alpha cells secrete a protein hormone called glucagon, and the beta cells, the more important ones as far as we're concerned right now, secrete a protein hormone called insulin. These are the two principal hormones that regulate our blood sugar level. There are many hormones that affect our blood sugar level, but these are the two major ones. Now, insulin's action, when it's released, is it promotes the uptake of glucose by the cells of our body. It circulates in the bloodstream. It makes your cells absorb or take up glucose. For most cells, when they absorb glucose, they use that glucose as a source of energy to make ATP. In the case of the liver cells, insulin causes the liver cells to take up glucose, and most of the glucose absorbed by the liver cells are temporarily and reversibly joined together into a polysaccharide called glycogen. Now, glucagon, released by the alpha cells, has the exact opposite action. It actually causes the glycogen that's in the liver cells to be broken back apart into glucose and re-released into the bloodstream. So basically, insulin lowers the amount of sugar in our blood, and glucagon raises the amount of sugar in our blood. Okay, now, again, we're going to focus mostly on insulin. This is a question, when do the beta cells normally secrete insulin? They normally secrete insulin whenever you have too much sugar in your bloodstream. Because whenever you have high blood sugar levels, the beta cells release insulin, and that causes the sugars in the blood to be taken up by the cells, including the liver cells, lowering the amount of sugar in the blood so it doesn't remain high. So then we might ask, well, when would your blood sugar level normally ever become high? When would you have these high blood sugar levels? And the answer is after eating a meal. When you eat a meal, you eat food, the food is digested, and these nutrients are absorbed into your bloodstream, and as you absorb the sugars from the carbohydrates you ate, your blood sugar level rises. So this is known as the absorptive state. It's the time during which you're absorbing the nutrients from a meal. So at that time, the high blood sugar level causes or triggers the beta cells to release insulin, which is going to lower the amount of sugar in the blood. All right, this is page S2. This is really showing the absorptive state. If the person is absorbing nutrients from their digestive tract, they are absorbing sugars and amino acids and other nutrients into the bloodstream. And this is when insulin is released into the bloodstream from the beta cells of the pancreatic islets. And insulin causes the glucose to enter cells in the body. For most cells, it's going to be broken apart as a source of ATP, but insulin also causes glucose to enter muscle cells and be turned into muscle glycogen, and more importantly, insulin causes glucose to go into liver cells and be stored as liver glycogen. And why that's more important is because this is a reversible process. It's a reversible process where the glycogen can be turned back into glucose and re-released into the bloodstream when the blood sugar levels become too low. The glucose stored in muscle cells, it's not a reversible process. The glucose that enters muscle cells can only be used by those muscle cells. In the top diagram, it's just showing in a large picture of a liver cell, and it's simply stating what we've already mentioned, that insulin causes glucose in the bloodstream to be taken up into the liver cells, and the glucose molecules are snapped together into this polysaccharide called glycogen. And that process of turning those sugars taken up into the liver cells into glycogen is called glycogenesis. Great word, it literally means to make glycogen from glucose. And as we can see, there are other hormones, including glucagon and epinephrine, that promote glycogenolysis, the breakdown of that glycogen back into glucose, and its re-release into the bloodstream to raise the blood sugar levels. So this is basically, in essence, how your blood sugar level is regulated. All right, so with that as the background, let's look on page S1. And so what are the actions of insulin? So we wrote that insulin increases the uptake of glucose into cells. It also promotes the uptake of other nutrients into cells, including amino acids. It overall promotes what are called anabolic processes. Anabolic means growth and healing. So insulin, the reason why, at least in part, insulin is absolutely essential to life is that it is the essential hormone that promotes the growth processes of the body, including healing. For our body to regenerate and heal, it requires synthesis of proteins, synthesis of nucleic acids using these nutrients, and insulin promotes all that. What are the general symptoms of having diabetes? So if somebody has diabetes, they have a fasting blood sugar level. When they measure the amount of glucose in their bloodstream, even after fasting for 12 hours, if it is greater than 126 milligrams of glucose per deciliter, or 126 milligrams percent, that's considered hyperglycemic. Now, it's not so much that I'm going to test you on what a normal blood sugar level should be, or what's the cutoff line, but understanding that there is a cutoff line, that when that blood sugar level, that fasting blood sugar level is higher than 126 milligrams percent, that's the definition of being diabetic. It's a little bit like, what's the definition of having high blood pressure? The definition of having high blood pressure is a blood pressure that exceeds 140/90. So there are definitions for everything. Now, what's become even more important than measuring the amount of sugar in somebody's bloodstream when they're fasting is known as the glycosylated hemoglobin test. This is really the standard now. It's known as the Aca A1c Test. And if the glycosylated hemoglobin exceeds 6.5%. Now what that means is that the sugar that's in your bloodstream, it's in the plasma, it's circulating in the bloodstream, some of that sugar enters the red blood cells and binds. It attaches to the hemoglobin in the red blood cells. And so if somebody's got too much sugar in their blood, they're going to have abnormally high amounts of sugar attached to the hemoglobin in their red blood cells. So when the amount of hemoglobin that has sugars attached to it exceeds or becomes greater than 6.5%, that's actually considered the best indicator of having diabetes. Because this is not just a single-framed, single-shot view of what the blood sugar level is. This is really an indication of the chronic state of being hyperglycemic. You'll notice that glycosylated hemoglobin level, about 6%, is therefore equivalent to having a fasting blood sugar level of 126 milligrams per deciliter. Another symptom of having diabetes, besides elevated blood sugar levels, is having sugar appear in their urine. Normally, there should never be sugar in the urine. But as these levels of sugar accumulate in the bloodstream, because there's not enough insulin to make it go into the cells, the sugar spills over, as it were, into the urine. And literally, as the blood flows through your kidneys, not all of the sugar that's being filtered by the kidneys can be reabsorbed back into the bloodstream, so it spills over and ends up in the urine. This presence of sugar in the urine, which normally should not occur, is called glycosuria, literally sugar in the urine. Now, in fact, when sugar starts to spill over into the urine, it osmotically drags water with it. So as the sugar is moving from the bloodstream into the urine, it osmotically pulls water along with it, and that creates what's known as an osmotic diuresis. The person has to pee a lot. They urinate a lot. This is called polyuria. It just means frequent urination. So this is a classic indicator of diabetes. Now, incidentally, because the person is urinating a lot, they're losing water from their bloodstream, from their body, more than they should, and they tend to also have a dry mouth, xerostomia. And that's going to affect salivation and oral health. Another thing that develops in diabetes, especially type 1 diabetes, is ketoacidosis. And this is the buildup of what are called keto acids in the bloodstream. If the cells are not able to utilize sugars as a source of energy, they start to break down and use fats and proteins at a faster rate than normal as a source of energy. And the breakdown of fats and proteins as a source of energy forms these byproducts called keto acids. And this creates a condition known as ketosis or ketoacidosis, ketonemia, elevated keto acids in the blood, and ketonuria. Keto acids start to even appear in the urine. So all of these are classic signs of possible diabetes. On page S3, so here in this chart, we've indicated what's the normal blood sugar level. The normal fasting blood sugar level should be below 100 milligrams per deciliter. If the fasting blood sugar level is higher than 126 milligrams per deciliter, they have diabetes. If it's between 100 and 125, that's called pre-diabetic. It's a little bit, it's like borderline diabetes. It's a little bit like being borderline hypertensive. You're not, if your blood pressure is 135 over 85, you haven't exceeded 140 over 90, you're not yet hypertensive, but you're borderline, you're getting there. And that's when the doctors are going to start raising the red flag. They're going to say, hey, you got to be careful, because if you don't get this under control, you're going to be on medication soon. The glycosylated hemoglobin level should normally be below 5.7%. Borderline is between 5.7 and 6.4%, and if it exceeds 6.5%, so that's diabetes. Now, there are many problems that develop in diabetes. But the most serious problem in chronic diabetes that's not managed as sufficiently is microvascular disease. This is the fundamental problem, is that little capillaries and little blood vessels in the body undergo inflammation and show pathology, vascular pathology. We call that angiopathy. Angiopathy means pathology of the blood vessels. Angio means vessels. Let me try to convey to you what's going on with somebody with diabetes and why they develop this vascular problem. And some of you are familiar with this because you've even heard that some people who have had chronic diabetes have such poor circulation, including to their extremities, to the point where they have to amputate a leg, a limb. So clearly this is a big problem of this poor circulation. So let me try to convey to you some imagery that may not be fully accurate, but I think it encapsulates what's going on. Imagine that as the amount of sugar in the bloodstream is getting higher and higher, imagine the blood is almost becoming more like syrup instead of blood. It's got so much sugar in that blood plasma that it's gooping up the vessels of the body. And this higher than normal levels of sugar in the bloodstream, those sugars are attaching to cells, they're attaching and binding to proteins, in the cells, in the walls of the vessels, and it's literally just gooping up the walls of these vessels with too much sugar. I think that kind of gives you a visual image of what happens when the blood is becoming syrupy sweet beyond normal. So this leads to glycosylation of proteins in the walls of the vessels. What does glycosylation mean? Glucose, sugars are attaching to the proteins. There is impaired ability of the blood vessels to dilate. There is chronic inflammation. And there is also problems with blood platelets where there's an increased tendency of circulating blood platelets or thrombocytes to attach to the walls of the vessels and trigger blood clots. So overall, this poor circulation, this problem with the blood vessels becoming all clogged up with sugars is called angiopathy, a disease of the vessels. Now, this is occurring in all the blood vessels of the body. When you get angiopathy of the blood vessels in the retina, so that's going to affect the ability to see, and that's called retinopathy. And so people with chronic diabetes, it may lead to blindness. It may lead to impaired ability to see, as these little capillaries that nourish the eyes are just getting gooped up with sugar. There's going to be poor circulation to the nerves, the peripheral nerves of the body, leading to neuropathy, including neuralgia, neural pain. Some of you may have heard of people who have diabetes and they have chronic pain associated with neuropathy of their peripheral nerves. It's impairing the ability of the kidneys to filter the blood, causing nephropathy. The kidneys aren't functioning as well. So you can see this vascular problem really starts to affect everywhere in the body. So what started out as just a hormonal problem where you had too much sugar in the blood starts to become much more serious. Whenever you're not getting adequate oxygenated blood to any tissue of the body, it creates pain. There is impaired ability for healing of wounds. Remember, insulin is normally essential for healing and anabolic processes, growth and healing, and this whole insulin mechanism isn't working right. So there's impaired healing of wounds and injuries. There is an increased risk of infection. Now, one of the factors of why increased risk of infection is because of a decreased functioning of white blood cells, leukocytes, but I believe that another reason for this increased risk of infection is, again, imagine all of this sugar in the blood, and when you've got higher levels of sugar in the bloodstream than normal, that provides a perfect breeding ground for certain infectious agents, especially fungal infections. So there's an increased risk of candidiasis and mucormycosis. These are just fungal infections. They love sugar, right? It's interesting. If you have strawberry jam, strawberry preserves, it's got so much sugar in strawberry jam that basically bacteria can't grow in it. You know what can grow in strawberry jam? Mold, fungi. They'll grow on it. They love sugar. So you've got imperfect growth media with all that sugar for fungal infections. All right, we also wrote that from a dental oral perspective, there's increased risk of dental caries or cavities, increased risk of periodontal disease. A lot of this is because of the xerostomia, the dry mouth, because of the increased urination that we've pointed out. Now, as we've said, there are two major categories of diabetes. Type 1 diabetes, also known as juvenile onset because it develops during childhood, more commonly today called insulin-dependent diabetes mellitus, because in this problem, in type 1 diabetes, this is an autoimmune disease where the white blood cells in the immune system of the body attacks and destroys the beta cells in the pancreatic islets that normally make insulin. So essentially, after the immune system destroys these beta cells, this person with type 1 diabetes cannot make insulin. So they have to take insulin. They don't have insulin to secrete. So they have an absolute deficiency of insulin. Now, this type 1 diabetes accounts for less than 10% of people with diabetes. that means that more than 90% of diabetics have this other type called type 2, which we'll get to. Now, while most people with type 1 diabetes, it develops during when they're 9 or 10 or 11 years of age, maybe developing as a teenager, there are a small number of type 1 diabetics who only develop it later in life. It is still an autoimmune disease. It's given a fancy name. I'm not testing you on it. They'll call it latent autoimmune diabetes of adults, or LADA. It's an autoimmune attack, but it was delayed, and it only develops later in life, but it's still type 1 diabetes because it's an autoimmune disease. On page S4, so the more common diabetes that you have to know about is called type 2 diabetes. It's also known as maturity onset because it's more commonly is seen developing in people in their late 40s and 50s and 60s. It is also known as non-insulin dependent diabetes mellitus because in this case, the beta cells of the pancreatic islets are still secreting insulin, but the target cells of the body, the tissues of the body, are showing insulin resistance. They are not responding to the insulin. Now, as far as why this resistance to insulin, why do the cells of the body stop responding to this insulin hormone? The theory behind this is, the fancy terminology is downregulation. And I'll try to just, again, convey this in an overly simplified way. If somebody is eating a lot of sugar, and remember, sugar includes one of my favorite foods, bread, because all that bread is just a bunch of sugar, it's carbs. So our French fries, you know, and everything else, potato chips, it's all carbs. So if somebody's eating a lot of carbs, they're absorbing a lot of sugars all the time, and every time their sugar levels start to they start to absorb sugars into their bloodstream, their pancreas releases insulin. So they're basically eating a lot of sugars and releasing insulin and eating more sugars and releasing more insulin. Cells of the body stop responding to the insulin. They actually make fewer and fewer insulin receptor sites, and the insulin just isn't working anymore. So this is called a downregulation. Anyhow, in this case, the patient most of the time will not need to take insulin because they are making insulin. But what they're going to do with other drugs, oral anti-diabetic drugs, is to, at least in part, increase the sensitivity of the cells to insulin, because they are making it. Now, who gets type 2 diabetes? Not surprisingly, it has a strong genetic component. So something that I commonly say is choose your parents wisely. In other words, if diabetes runs in families, so if you have grandparents with diabetes, you know what, guess what? Their children and you're their grandchild, you have a higher risk of diabetes. Among identical twin studies, if one identical twin has type 2 diabetes, there's a 75% probability the other identical twin will similarly have type 2 diabetes. So that's considered a very strong genetic co-relationship. Other things that exacerbate, that make this problem of type 2 diabetes worse and may trigger its onset at a younger age than it otherwise might develop is being overweight, not getting enough exercise, especially cardio, aerobic exercise, eating foods, eating a lot of carbs in the diet. Don't become over 45. That's another risk factor. Oops, it's too late for me. Okay, having high blood pressure. Again, we're going to get into metabolic syndrome. Elevated triglyceride levels, those are fats, and elevated LDL. We talked about that when we dealt with cholesterol levels. That's the bad, evil, low-down, dirty, low-density, lethal lipoprotein that transports cholesterol to the walls of the arteries. Also, another risk factor is for women if they developed gestational diabetes. In other words, when they got pregnant, there are some women who develop diabetes just when they're pregnant. That's called gestational diabetes. It goes away after pregnancy, but if they did develop gestational diabetes during pregnancy, they are at greater risk that they will develop type 2 diabetes when they're older. Also, if their baby weighed more than 9 pounds at birth. Now, what's the problem with type 2 diabetes? The biggest problem is angiopathy that we talked about, the pathology of the blood vessels. That's really the most serious problem. There's an increased risk with the type 2 diabetes, there's an increased risk of developing atherosclerosis. You'd say, okay, so who cares if the walls of the arteries get clogged up with fat? Then they're going to develop high blood pressure. So you can see these are interconnected. Coronary artery disease, which is the name for atherosclerosis in the coronary arteries, high blood pressure. If you have type 2 diabetes, you're more prone to develop obesity, to develop retinopathy, nephropathy, neuropathy, all kinds of apathies. Periodontitis, an apathy of the gums and sockets of the tooth. Mycotic or fungal infections, more prone to develop gestational diabetes during pregnancy. And depression, if that weren't bad enough. Just throw that in. Now, how do you treat type 2 diabetes? It is treated first with diet and exercise. Many patients can, if not prevent type 2 diabetes, at least delay the age at which they do develop type 2 diabetes by watching their diet, consuming or ingesting less carbs, and doing more cardio or aerobic exercise. And then, eventually, they're going to need what are called oral anti-diabetic drugs. And in a small percent of patients, about 30% with type 2 diabetes will eventually need to inject insulin. Now, again, that means 70% will be able to control their type 2 diabetes without having to inject insulin every day. But about 30% will be so severe that they will need to take insulin because diet, exercise, and orally anti-diabetic drugs will not alone be sufficient. On page S5, so on S5, what are the possible ways, the possible mechanisms that we could use clinically to lower the amount of sugar in the bloodstream? If the fundamental problem of diabetes is there's too much sugar in the blood, how can we lower the amount of sugar? One way is to increase the secretion of insulin. Now that's possible in type 2 diabetes because the pancreas is still able to make insulin. So we have drugs that can stimulate those beta cells to secrete even more insulin than they normally would. Remember, in type 1, that is not a solution because the beta cells no longer work. They've been destroyed. A second approach could be to give drugs that lower the release of glucagon. Glucagon is the hormone that raises the blood sugar level. If insulin's the hormone that lowers it, if glucagon's the one that raises it, so let's decrease the release of glucagon. So either increasing secretion of insulin or decreasing secretion of glucagon or both. Another approach is to increase the sensitivity of insulin receptor sites so that whatever insulin is being secreted, the cells respond to it. They become more sensitive to the insulin instead of resistant to the insulin. A fourth approach is to take a medicine that reduces the absorption of sugars from the digestive tract into the bloodstream. So there are drugs that decrease uptake or absorption of sugar from the GI tract, and that will tend to lower the amount of sugar in the blood. Another approach, number 5, is to decrease the release of sugar from the liver. And you might say, well, what do you mean? I'll remind you that we said that sugars are stored as glycogen in the liver, and if we can use drugs that reduce the release of that sugar from the liver into the bloodstream, that will also tend to lower the amount of sugar in the blood, so by affecting the liver. And another approach, number 6, is to give a drug that inhibits the appetite center in the hypothalamus of the brain. So the hypothalamus is an area of the brain that has a lot of control centers. There's actually what's called an appetite center, and the opposite of that is a satiety center. So the appetite center is in the hypothalamus of the brain, and that's what causes one to have a physiological drive to want to eat. And the satiety center, the opposite of appetite, is being satiated, satisfied. So that's the center that makes you not have the physiological drive to eat. So if we can either inhibit the appetite center or stimulate, activate the satiety center, that should also reduce the desire to want to eat foods, especially carbs.